Good morning. I'm Larry Boris, Executive Director of the National Association of Worksite Health Centers. I want to thank you all for joining us today. Unfortunately, one of our speakers, Ann Hopkins from CHG Healthcare, is in the middle of a snowstorm, and she is unable to be with us today. Fortunately, we've got myself and Mike Thompson from the National Alliance of Healthcare Purchaser Coalitions who will be joining us. We'll do more of an interactive group since we'll have more time than I thought we would. And we hope that you will be able to share with us not only your questions, but also your experiences in offering behavioral health services at the worksite. So let me just get started with introduction a little bit. For those of you who are not aware or familiar with our organization, NAWHC is a nonprofit organization for employers, union sponsors of on-site, near-site, mobile, and virtual health centers. We also provide services and have members from the vendor community and the health provider community, consultants, and others who are interested in worksite health centers. We provide assistance in the development and management of those centers and providing benchmarking services, educational programs, a variety of research, and a true collection, a clearinghouse of information on all aspects of on-site, near-site, mobile, and virtual healthcare. We hope that you'll participate in our annual program, September 8th and 9th in person in Nashville, Tennessee, which will be a day and a half for a real drill down of this area. There's other programs and activities that you can participate in. Go to nawhc.org for all of that information. These are the two programs that are coming up. Next month, we'll have a program on, now that you've finally selected a vendor provider, how do you implement this at the worksite? So what is the implementation stage? And then, as I said, our annual forum in Nashville. Today's speakers, again, I'm going to jump on and add a little bit more than I typically do to provide some information about our experiences. As I said, I am Executive Director of NAWHC, and prior to that, I was the President and CEO of the Midwest Business Group on Health, a large coalition of self-funded employers in the Chicago area that really focused on getting more value from healthcare spend. Our primary speaker, fortunately for us, is Michael Thompson, President and CEO of the National Alliance of Healthcare Purchaser Coalitions, the only nonprofit purchaser organization with both a national and a local structure dedicated to driving health and value across the country. Prior to that, Mike had a distinguished career at PricewaterhouseCoopers for 20 years as a real thought leader in this country. So let's get started. So what has been the need? There's a recent survey that was done by Teladoc, which is, for many of you might recall, is a large leading vendor of telehealth services. And so they had an outside consultant do a survey of users of so many of their employer clients to find out about their need for behavioral health services and how it changed both from the middle of the pandemic to currently. And what it found is that, in fact, we continue to have increasing needs in a variety of areas for a need for mental health services. For both depression, it's gone up from 58 to 70%. Anxiety's gone up to 82%. Trauma and stress disorders over 58%. Feeding disorders, sleep, substance abuse, and other behaviors all are increasing. So despite the fact that we seem to be getting a handle on the COVID pandemic and people are coming back to work, the stressors continue to be there and continue to be worse for people who are coming back to work and for those who continue to work in remote locations. Another survey that was done of the broker community by some of the leading broker associations found that employers are investing more and more into mental health services. And when they look at their clients over historical trends, you can see over 90% are increasing their investment in mental health services compared to previous years. So the dramatic change over time, and particularly during COVID, looks like it's something that will continue to increase with time. And so this is an important and timely area. When we do surveys of employers with worksite health centers, we find behavioral health services tends to be one of the top 1 or 2 priorities for them in trying to maintain and establish this for the efforts. So a survey, again, one that was done of what services are valued by workers, find that in fact, both in-person and virtual visits are those services that people are taking advantage of. You know, prior to the pandemic, many employers had nurse hotlines, nurse advisor call lines, and it was only about 10 to 20% of people took advantage of those. During the course of the pandemic and since then, the level of confidence in using an online or telehealth person increased dramatically. Their confidence and the security of the information and being confident talking to someone over a screen or over the phone has been important. And so we find that people's experiences, particularly as relates to mental health, where they want something in a confidential, easy, accessible way, has grown dramatically. And so we're finding both kinds of services, both online and in person, are things that people really value and should be part of an employer's arsenal of benefits that they offer. And appropriately, employees are really willing to accept these kinds of services from an employer. Many people had said, well, people won't trust the employer to give this kind of information, or they won't trust the people who are providing it. But in fact, 8 in 10 of people who seek out mental care are much more comfortable in using services provided by their employer than perhaps it was thought previously. So with that, I'm now going to share my screen with Mike Thompson's information. So just bear with me while I pull that up. And I'll have Mike start his. Mike, just tell me when to start going. And
just go to the first slide here, and we'll
go to the first.
So, yeah. So, just a little bit of background on me. While I lead the National Alliance, and we have a very broad agenda, I personally have been very active in the area of workplace mental health for probably 20 years. I've had personal history in this area. I have invested a lot of time in the workplace mental health arena, in the mental health arena more broadly, and I've spoken on it, probably dozens of times. So I did go back to the prior line, a little bit on the National Alliance, prior slide, Larry. I don't know why it's shifted.
No, I will do that. Just bear with. Okay.
On the National Alliance. So we're the umbrella organization for employer coalitions across the country. There's about 45 coalitions across the country. They are made up of large employers, Fortune 100 companies, down to mid-sized employers, typically in the self-insured, but also public sector, cities, states, school districts, and union groups like the UAW Trust, 32BJ. So very broad, collectively represents around 45 million. And we focus in 3 primary areas. And you're going to see that all of these areas at the end of the day tie back to mental health and the strategy. So delivery and payment reform, total person health, health policy, and again, we've had a special focus on mental health, race, health, and equity in COVID during this most recent period. Go to the next slide, Larry. So Larry just showed you some data. Our data looks almost identical to Larry's data. So when we look at all the strategies that employers have, you see that number 1 over this past period in 2021 was mental health and substance use access and quality. Not only was it something that employers were currently doing, but they were planning to do it, so that 92% had some sort of strategy in this area over the next 1 to 2 years. I also point out on this slide this issue on health equity and advanced primary care. While they're less common as a current activity for the employers in our survey, it is one of the highest priorities moving forward as well. So health equity, and we'll talk a little bit about that, in advanced primary care, where we have said, and I think this is very relevant, when you're looking at on-site clinics, that it's not advanced primary care unless you've integrated behavioral health into that experience. So next slide. So it's no secret that, the mental health issue has become front and center for employers during COVID. We talked about that a lot, but it was also a major issue before COVID too. And we had a framework around this. Now, I want to just kind of share that framework because I think it's still valid today, but you'll see that it's evolved somewhat. And I'm going to talk about how it has evolved going forward. So when we had a framework around mental health, we started with these 4 pillars. So the first pillar was know the impact. So why do you need to know the impact of mental health? Well, it's why you do everything else. So it has a huge financial impact, has a huge impact on business performance, has a huge impact on employee engagement and loyalty. It has a huge impact on other services, underuse and abuse. And in fact, if you tie that together with the impact on other medical conditions, I think if you look at a Milliman study, you'll see that the indirect costs of mental health, even for medical costs, is probably twice as great as the direct costs of medical direct. And then that doesn't include all the productivity elements, which I think all of us would recognize are, again, a multiple of the impact of the cost of treatment on mental health. The second big area was break the silence. And this really kind of speaks to the issue of stigma and readiness. Stigma in the sense of, are people accepting that, in fact, mental health is a life condition. It's something that people need to deal with if they're having issues around depression, anxiety, or any other mental health condition, but also acceptance within the organization itself and readiness within the organization itself. And so what are the signs of a mental illness? What do I do if I see these signs among some of our people? How do I support them to use the resources that are available? And what we have found is that there's a number of different type programs that employers have used to kind of break this silence. Leading companies like American Express or DuPont, for example, have had campaigns around those things. It almost doesn't matter what campaign you use, you get the same result. And the same result is that employees actually embrace the company for being open about mental illness and mental well-being. The more you're open about it, the more open they are about it, and the more engaged they tend to be in the programs that are available and whatnot. And obviously, the more vulnerable that openness becomes, again, mental health, I think this audience would know, is a condition that mental illness is a condition that impacts 1 out of 5 individuals in the working population. And then when you think about their families and their friends, you're probably talking about, most of us have been exposed to the impact of mental illness in our friends and our families. And with that, when you kind of break the silence, people kind of open up in that regard. And so that's important. Leader activation obviously is important. And some organizations have gone so far as to have employer resource groups on this, just like they would have something for people who have been, different cultures or races, Blacks or Hispanics. There are some companies have gone so far as to have employer resource groups around mental illness and neurodiversity and things like that. So there's a lot in this kind of acceptance modality, improving the culture. And frankly, as I have said, this is an area that is going downhill. Most major companies have already moved in this direction and are making a major play to support their employees to move forward. What has not been as positive a picture has been affordable access. So even if you're more effective at preventing mental health or mental health issues or mental illness, The issue of access is a very serious concern. And of course, EAPs have been a ready source of access historically, continue to play an important role. They tend to be way underutilized. And there's a lot of issues around that. A big concern is the behavioral health networks that are in the plans. And the big concern on that has tended to be around the ability to get an appointment if you're a new patient. We're going to talk about that more broadly. And what you're seeing is an explosion of adoption of supplemental resources for behavioral health, adoption of vendors like Lyra and Ginger and many others. There's really a lot of different players that are in this behavioral health sport, and many of those are enabled by technology and virtual support. Some are actually becoming creative on how to provide supplemental network support as well. And then I talked about advanced primary care, the idea that behavioral health should not be kind of ignored in that primary care experience. It ought to be part and integrated into that experience. And we'll talk a little bit more about that. Finally, the last pillar is culture of well-being. And why well-being? I'll talk about that in a second. Every organization, I think, at this point has some focus on well-being. But I think when you're thinking about a mental health strategy, it's very intertwined with that well-being strategy as well. And you talk about tone at the top, the environment, skill building, total health focus. Go to the next slide, Larry. One of the points I would make that I don't think is always fully appreciated. A lot of times when we think of our well-being wheel, and everybody has their own different wheel on well-being, mental health will be part of that wheel. What may not be fully appreciated, though, is when you're looking at how to prevent issues in the mental health space, all those elements, physical, social, mental, intellectual, spiritual, purpose, financial, all those things impact your mental health. And if you're dealing effectively more broadly in your well-being structure, you're also dealing with the issues around mental health as well. And of course, I think we are familiar with the huge leverage associated with dealing with the broader well-being. What's going on there, Larry?
Sorry, go ahead.
Can you bring it back to that wheel? Because I think it's...
I will do that, sure.
And you probably want to put it in full slideshow mode.
I will do that.
Yeah. So, and again, fewer unhealthy days, less likely, more easily adaptable to change, bounce back from illness, all those other dimensions on this. And this also ties into the discussion around total person health or whole person health that we'll talk more about afterwards. Go to the next slide. So now in the context of the pandemic, even early in the pandemic, we knew that this was going to be an escalating issue during the pandemic. And some of it was economic stress, some of it is the fear of the virus, issues around social isolation when people were isolated at home. And frankly, maybe not as anticipated, was the increasing demands and pressures, both from the home standpoint. Larry, can you pull down those things? Because you can't see the full slide when you're doing that, at least on mine.
Sorry.
The home, family, and work. So so part of the point I want to make here is there is multiple dimensions when you think about mental health, when you think in the context of stress. So one of the things I learned 20 years ago from Lyle Miller, who was a PhD out of Boston, is he had an econometric model around stress. And what he learned in actually studying the data is that demands and pressures, and now we're talking about things at work, but demands and pressures at home, child care and other type demands, stress with a spouse, whatever it might be. Those are additive and cumulative. So first of all, additive means that one thing piles on each other, and cumulative means it doesn't matter as much if you have a short-term demand pressure as if it never goes away. If work is always on overdrive, if the issues I'm having at home with my child are always there, it becomes cumulative, additive and cumulative. And if he looked at the outcomes of that, what he found is that if you saw those additive and cumulative pressures, that would go there. What he found that is people's ability to cope with those activities, their coping skills, their resilience, that actually had an impact on outcomes, but it predicted about 16% of the outcomes. But the demands and pressures themselves predicted 60% of the outcomes. And this is very important. So when you're thinking about how do we mitigate the impact on mental health and frankly, other outcomes related to stress, you need to be focused upstream on the actual demands and pressures themselves. And if you relieve any of those demands and pressures, you relieve all of those outcomes because of that additive and cumulative. And second of all, things like taking a break, having a vacation, turning off on the weekends relieves that cumulative impact of demands and pressures as well. And so that's why, from a mental health standpoint, you need to be very cognizant of it. Clearly, during the pandemic, this stuff added up. The longer we were isolated, the longer we were exposed to the virus and feeling unsure about that, the more we had economic stress, all that stuff's added up. And you saw it in some of the data that Larry showed earlier in terms of what happened. This is why we tracked the risk of mental health issues through the mental health index during the pandemic. Next slide. And I'm taking a little longer on this than I would have if I was kind of sharing the term, but I'd be very open to conversation with anybody if Larry, if you see any questions or if people have observations they'd like to share. So that's kind of that broader context of the demand for mental health services during the pandemic. I'll also say that this issue of access and quality actually existed pre-COVID. In fact, we had an initiative called the Path Forward for Mental Health and Substance Use even before the pandemic. But of course, all those needs only got exacerbated during that. And that comes into these 5 basic areas: network access, which again is the ability to actually get an appointment with somebody in the networks; collaborative care, which is the model that integrates behavioral health into primary care. And there's multiple models, but the collaborative care model is one of the most evidence-based models that actually shows that if you do integrate into primary care, you can actually achieve not just better outcomes for mental health, but it actually can cost less. It will reduce the need for other services within the plan. Measurement-based care. Measurement-based care is the idea of using a PHQ-9 or GAD-7 or other type mental health assessment tool, both to actually diagnose the need for services, but also to follow the care afterwards to determine whether or not you're having an impact with the interventions that you're applying. And the interventions could be cognitive behavioral therapy, or it could be medications. In either event, there's a lot of variation on whether those services and or medications are actually having the impact that's intended. And if you're not following and measuring both at the beginning and afterwards, you can't really know. So the impact of measurement-based care, the studies are showing, is about 20 to 60% better outcomes if you integrate measurement-based care into the care. The fourth area is telebehavioral health, and it's turned out that this is something that has exploded during the pandemic, and the gains because of this has actually improved significantly in terms of the access equation. And as Larry indicated, we actually see very comparable outcomes from telebehavioral health. Telebehavioral health also allows us to integrate into primary care as well. There are good models that integrate through a virtual platform rather than being co-located. So co-location is neither sufficient, co-location alone does not lead to integrated behavioral health, nor is it necessary. You could potentially integrate without being co-located. And that's a practical way if you have a small practice. And of course, parity is a key issue as well. So go to the next slide, and you can see there's a number of different organizations that are collaborating on this. So what were the priorities during the pandemic? Clearly telebehavioral health. People were not going in person during the peak of the pandemic, and telebehavioral health just exploded. And that's been very positive. Also, though, is screening and testing for behavioral health issues, mental health, substance use. And just like we were screening for the virus, screening for these issues became more important during the pandemic. The good news is that got built into a lot of our processes during this period. And then finally, integration of behavioral health into primary care. Most medications for behavioral health, for mental illness, are actually prescribed in fact, the great majority are prescribed in primary care. Yet the level of treatment and the quality of treatment is very uneven in primary care. People basically were not trained in this domain, and many primary care practices and probably many on-site clinics choose not to engage actively in behavioral health because they're not sure what to do if they find something. And so I think we just need to be more diligent, more deliberate to integrate into primary care. That's where employees and their families actually want to get their care to start with. And yes, some of it will require referral, but a lot of it can in fact be started and managed through the primary care type experience. Next slide. So thinking forward, what is that broader picture on how we manage mental health? So on the one hand, I think we want to think about the demand side of the equation, flattening the curve of emotional health concerns. Again, think about that demand and pressure picture. 60% of the outcomes are predicted by demands and pressures. And this is where I think corporate America or organizations more broadly really did step up during the pandemic. They were very cognizant of staying close to their people, supporting their people, avoiding that isolation as much as possible, being more flexible in how they dealt with employees and their needs, their childcare, all of that organizational and program support to reduce the cumulative and the additive and cumulative stressors that were impacting their employees and their families. Certainly education on self-management, their ability to cope, how to deal with those issues more effectively. And remember, those issues are not limited to their mental health. It's also those issues around financial constraints or other elements. This idea of creating a purposeful environment, firms of endearment, and that broad focus on employee well-being. So that's kind of the preventive side of the picture, and totally appropriate, and frankly had a huge impact during the pandemic. The other side, though, is to pivot in terms of the support that's available to our employees and their families. No matter what you do on the upside, there's still going to be people that are going to have need for services. And with that, we need to raise access and the quality standards for telehealth, telebehavioral health. The good news is because those platforms tend to be technologically enabled, most of those platforms systematically integrate behavioral, like measurement-based care into those platforms. Even though most specialists still don't use a measurement instrument, most primary care does not use a measurement instrument, they were in fact systematically included in the telehealth and telebehavioral health platforms. Promote virtual integration of behavioral health and primary care. The idea that we're providing, whole person support and yet we ignore behavioral health is I think just not acceptable or not even logical at this point. And then standardized screening and follow-up across the board. Again, it's not that it's more likely that there's a mental health issue than there is many, many other things that we screen for. And yet we choose not to screen for in this area. And it's more likely that the intervention doesn't work in this area. And part of the success rate of having those much higher outcomes is follow through, actually remeasuring to make sure we're having the impact we intended when we did the intervention. Next slide. So then the other dynamics that have occurred during this during the pandemic is obviously the escalation of the social justice movement, and frankly the huge raising of awareness of the issues of inequity within the system for race, by income, by culture. And I think as we think of this picture more holistically, behavioral health is part of that picture, but so are the issues around social needs and social risks, and the issues of racial relevance or cultural relevance and discrimination in that. And with that in mind, we have at the National Alliance developed a framework around race, health, and equity. And the building blocks of that almost sound very similar as the building blocks we talked about on mental health. So understanding impact of differences, actually looking at things that data to understand where the differences are. There is data that exists at a community level, at a public health level, that will help to identify where differences exist. One of the areas where there's significant differences is in mental health, but it's totally intertwined, especially when you bring it up to the demands and pressures side of this equation, differences in financial pressures, differences in social pressures, all those elements, being aware and engaged on that and analyzing variation. And the way I choose to think about equity is with a quality mindset, and when you're trying to improve quality within an organization, you start with understanding where is there variation. And then you analyze that variation, and then you're intentional about addressing the variation. Where's things falling through the cracks? How do I deal with that? And that comes into that second pillar, which is about integrating equity into the strategy. So we're not afraid to look at the data. In fact, we're intentional about looking at the data. And then when we find differences, we analyze why those differences exist. And then we take intentional action to close gaps. And to do that requires breaking down silos, establishing metrics that address those equity issues, and then make sure that when we take actions, we see whether it has an impact to improve program effectiveness, et cetera. The next part is really supply chain. And this is where I think employers play a huge role in the entire system, whether it's in mental health or any other area, that if they raise expectations, not just in what they do internally, but what they do with external providers, they need to raise the bar of what they're expecting in building equity into the processes of their providers. And that can include their health plans, and include their vendors, include their on-site clinic vendors. How are you building equity into your processes? How are you being intentional about improving in this area? And frankly, what employers should be doing is building in more accountability in that regard as well. And then finally, thinking with that broader cultural lens of building inclusion in everything that we do, so that we're being more cognizant. I think I have one more slide, Larry, and then I'm going to stop. One more slide. So the last slide, I think, is the way we are framing this more broadly at the National Alliance, is this idea of thinking across the entire spectrum of well-being, thinking about total person health, bio, psycho, social. And so this is how it all wraps together. It turns out, my belief, based on what I have seen, is any system that is designed around the whole person tends to outperform any siloed type actions. And because these things are so intertwined, if you think too narrowly about mental health just this way without thinking about the interplay with the the biological issues and the social issues, you're going to suboptimize your approach. And I think I think this is part of what makes advanced primary care, for example, outperforming other models of care. And I think that's very relevant for on-site, near-site interventions as well. So if you go to the next slide, I think it's just comments. So I'll stop there, Larry, and see if any of that is helpful.
Thanks very much. It was, well thought out and a very broad perspective on it. What we'd like to do in the final 20 minutes or so is to go around the table and ask people, what are your thoughts about what Michael's covered, and what are you doing for either your employees or for the employer clients that you're working for? And so when I call your name, we'll try to unmute you and ask that you participate and give us your thoughts on that. So let me start out with Amy Trippett. Amy, you've done work at Northeast Business Group on health. Why don't you tell us about any of the work that you've done in your organization?
Sure. So thank you, Larry. So we have been very fortunate to be able to bring together not only employers, but large health systems, point solutions, and health plans into the conversation, both at a steering level perspective, but as importantly in a all hands on deck work group environment. And we are tackling all of the pillars that Mike spoke about. And very specifically, we have created some materials around helping to educate employees on the benefits of telebehavioral health. And while it may seem obvious, it really isn't. People have wanted to go back to in-person, which is terrific, but there's also still all of the issues that Mike talked about in being able to get an appointment, et cetera. We've also created a checklist for employers to use in their communication conversations with benefit consultants and third-party administrators in being able to collect their own data. And obviously we all know how important that is, but then understanding, when you understand what your data is, how you are able to act on the results of the data and improvements perhaps that need to be made in your plan design. And we are also getting ready to launch a really fabulous employer survey, which we'll be able to share much more about. And we are, in conversations about measurement-based care. Who's doing it? What does it look like? How is it working? And again, how employers can use the information about those providers who are practicing measurement-based care to help inform their employees on the areas in which they need to be asking providers about different, screening techniques, et cetera, when they're making their choices on choosing the best providers in their network.
Thank you very much, Amy. Appreciate you sharing all that. I'd like to ask Angie Trill from Onsite Care to give us her thoughts about what they've done. Angie, any comments or questions for Mike and thoughts about what your work has done? Okay. Let me move to Arlene King. Arlene from Concentra. Give us your thoughts on any of the comments and work that Concentra's done in this area. Arlene, take yourself off mute. Okay. Move to Cortland White. Cortland, comments and questions, your experience as well.
Sure. I work for an investor in the space, and we've been evaluating a number of behavioral only, or virtual only rather, behavioral providers that have kind of seen the pandemic as a accelerant to their go-to-market, but they are somewhat limited in that they're kind of virtual only. I'd be interested to hear any thoughts on, hybrid, in-person only, virtual only, and the merits and disadvantages of each.
Mike, you want to comment on that?
This is coming up quite a bit, and there are people who are more expert than I that will tell you, we're not in an era where there's never a value to having in-person meetings. Having said that, a lot of people have prefer to engage virtually. It turns out that the care is much more efficient delivered virtually, not just because of travel time and all of that, but also patients are more likely to keep their appointments and show up. So there's less dead time in the patient. So I think that there is, I think there is openness to, at a minimum, integrate virtual solutions into the process. I think there will continue to, I think it doesn't eliminate the need for us to address the issues on access to in-person treatment as well. And frankly, it goes beyond just in-person treatment. It's hospitalization and all that stuff for very serious mental illness. But honestly, telehealth has exploded, and I don't think we're going to want to put that back in the bottle. I mean, it's been a major way to help us to get practitioners to participate with the system. When all they do is practice out of network, what they end up doing is being sub-optimized use of scarce resources, and it becomes very much a two-tier system. Telehealth has allowed us to get more of those psychiatrists and other mental health professionals into the system and to be available for employees and their families. So I'm very supportive, and I think most people are very supportive, including that, but not, again, it still requires us to have that thing. Hybrid models make a lot of sense to me. There may be times that we can get care accomplished effectively offsite, but for some parts of the country, as you know, telehealth is probably the only approach that we're going to be able to deal with short term. So,
Great, thank you for your comments. Ed McNamara, Ed, could give us some thoughts on the perspective and what Corrupt Premise is doing in this area?
Yeah, sure. Thanks, Larry, and good conversation, Michael. Thank you for the prepared remarks. I'd say, very similar to some of the previous comments around a move to hybrid. During or prior to the pandemic, an overwhelming majority of the care at our sites was delivered in person. During the pandemic, our digital care delivery peaked at about 85% of visits occurring virtually across various product sets. We have definitely seen the mix of digital versus in-person return to about a 70-30 split, with a majority of the appointments being held in person, with the exception of one line of service, and that's behavioral health, still hovering around 70 to 75% of those visits being conducted virtually. So certainly seeing the member/patient populations continue to feel comfortable with it. And so those virtual visits can be conducted either with the health center staff, meaning behavioral health staff that's embedded within the health center, or via a centralized team. But all of them are offering the same level of care as it relates to solution-focused psychotherapy, short and long-term counseling, psychosocial assessments and treatment plans, and obviously various screenings for suicide, depression, et cetera, et cetera. So across our book of business, the number one most requested line of service being added to our sites.
Great. Thank you for sharing that, Ed. Thank you. Holly Richardson from Franciscan. Holly, your thoughts or comments? Holly, there you go.
Hi, Larry. My apologies. I actually just got to join, so I have missed most of this. Just trying to
Okay.
catch the tail end. So I'm hoping that there will be a recording coming out.
Yes, this has been recorded and the slides and recording will be made available.
Perfect. Thank you so much.
You're welcome. You're welcome. Kelly Moreno, Kelly, comments or questions, work that you're doing in the school districts?
Yes, good morning. We are new to this group, so thank you. The presentation was wonderful. We do run a health clinic here and I have 3 providers. My physician, we do not have mental health at this time. That is definitely on our wish list of things. Our carrier does offer mental health options online, but via telehealth, but honestly, it has been a difficult buy-in for our patient population here in El Paso. So we will do an initial visit here to determine the need. And then my staff will set them up with a follow-up visit with a behavioral health entity in El Paso. But we are like everybody else in the sense that those appointments are hard to come by, usually with a long wait in between, which is unfortunate. We can start medications here at our clinic until they do get that follow-up. But like I said, you know, El Paso is one of those very large, small cities. So I don't feel that we have the resources that we need. And that's why mental health is on our wish list.
Right. Thank you. Appreciate you sharing that. Mario, do you want to comment any more about the school district area? Mario Camella?
Good morning, everyone. No, I work along with Ms. Kelly Moreno. We, like she said, have the on-site clinic for our staff, and this is something that is somewhat new to us. So we're looking for some ideas and what's best practice or what's working in other sites. So thank you for the time. I don't have any questions at this point.
Okay. Michael Howard, Michael, good to have you join us. Any comments or questions, think work that you've done in the area?
Certainly. We have not done the work that we've needed to do, and we're working on a more intentional focus in this area. I think our employers were really kind of back on their heels with COVID, you know, managing the testing and managing the work site setup, and so were the clinics to start out with, and then you know the everything lasted on into the beginning of this year as far as staffing and whatnot. But now that everybody's back, everyone cannot ignore the behavioral effects of COVID, which have amplified something that was neglected before already. You know, we've had in our clinics that we've got installed EAP integration and, you know, screening tests during the annual HRAs. But now what we are very excited about is the opportunity to put in a virtual primary care with a behavioral piece as a wrap. And that area, we think, to Mike Thompson's point, will be a very, very, very good option because of people's likelihood of engaging where they don't have to go in person. And also, like he said, the likelihood of keeping an appointment. There are just a lot of upsides to that. And also to be able to get to a specialized staff member who, you know, is a dedicated behavioral health person that's not perhaps someone that you'd have to put in at the clinic if your size doesn't justify that. So to be able to get to that type of specialized expertise and then have them still on the same EMR is something that we think is very promising in a direction we're moving in.
Great. Thanks for sharing, Michael. Appreciate that. Tracy Rothenberger from Nordic Private Care. Your thoughts, comments, and experiences?
Yes, we actually have an on-site clinic here in Wisconsin, and we do actually offer behavioral health. We have behavioral health counselors that come in 3 days a week, and we kind of kept going through all the COVID things because we just had started up just as COVID was starting with our behavioral health. But through that process, we had to add another one. And just in a matter of probably the last 6 months, we've already seen 700 and some visits come over from the plant. We offer it to not only our associates, but also to their family members. They can come over during their work time and get the counseling that is needed. If the children are in school and they've established care, we do those televisits with them while they're still in school, or if somebody can't make an appointment, we offer them that. We're very proactive in this. Our company also's health plan covers assessments, whether, family members or the moms or dads, it's paid for 100%, any counseling sessions that may be needed. So this is something that we've worked on, like I said, over the last year and a half, really implementing, and it is growing, and it is a needed service. And our associates here really, enjoy and love the fact that we have it here for them.
Right. Thanks for sharing, Tracy. Michael, let me ask you, years ago, employers were reluctant to offer mental health services because they couldn't see an endpoint. There was no closed ending of the episode of care. How has that changed? And what do you recommend as far as measuring the value of these services that an employer offers?
I'm so old. I remember when we used to have limits on mental health for all those reasons. There was a real serious concern about use and abuse of services, and would this ever end, and yada, yada, yada. The reality is that when we lifted the limits, no skies fell, right? And in fact, if you've had mental health issues in your family or you have friends, you would be very cognizant. In fact, you look back at those limits and you go, how the hell did we think we could get away with that? It made no sense in the scheme of things. Are there some mental health conditions that have ongoing needs to meet or otherwise? Yes, there are. And it's like any other condition that sometimes has ongoing needs. Are there some interventions that are short-term in nature and nip it at the butt? Yes, there are. And I think that's why there's management and measurement in the system. The reality is a lot of people at one point had a sense that this is just throwing money at something that doesn't go anywhere. The reality is that 90% of the conditions in mental health can be treated successfully to fruition. And some mental health conditions are chronic, like other chronic conditions, and need to be managed the same way with the same attention to adherence and ongoing strategies to manage. So honestly, I don't hear those type of concerns expressed as often these days as many of us were exposed to 20, 30 years ago.
And let me ask you, EAPs so previous were measured by essentially utilization. Do you see now outcome measures that we can use for worksite centers that offer behavioral health services, or EAPs, or virtual vendors that we should be looking at?
Well, again, if you're doing measurement-based care, you should be able to understand your level of engagement, your level of outcomes for the interventions you're doing. I mean, that's no different than measuring blood pressure or other conditions, right? And I think yes, you should be able to do that. What goes unmeasured often doesn't go away, right? And what often manifests itself as another condition. If you kind of ignore this, I think it actually ends up costing more. It just doesn't show up in the mental health line. it shows up somewhere else. Low back pain or other type of conditions. And you're also, if there is an underlying mental health issue, oftentimes your adherence rates and other elements are confounded by people not being at their best in general. They're depressed or they're anxious and they're not taking their other meds and they're not doing this and they're not that. So again, I think that, again, I'm not a clinician, I'm not an expert in that regard, but the winning strategy is to manage the whole person and recognize that a big part of that, mental health, mental well-being, in doing so.
Great. Well, thank you. Thank you, Michael, for joining us and giving us your thoughts and experience. Thank you, everyone, for participating in the call. As I said, this will be recorded and sent out to everyone, as well as posted for the members on our website. So I hope you can join us next month as we talk about implementation of worksite centers. Everyone have a safe and healthy week. Look forward to seeing you again. Take care. Bye-bye, everyone.